Hi there, welcome back to the Parkinson's Disease Education Podcast. If you as a person with Parkinson's disease have ongoing issues with tremor, possibly movement problems like dyskinesia, this is going to be an episode for you. Today we're going to be talking about MRI-guided Focused Ultrasound, otherwise known as FUS, and we're going to be talking about how it's used to treat motor symptoms in those living with Parkinson's disease. This is a surgery, but it's not a surgery in the traditional sense in terms of the fact that there's no incision made, there's no implanted hardware. It's technically a non-invasive process, though it does permanently change some very specific parts of the brain, and we're going to dive into that in this episode. So let's break it down into what it is, how it works, who it's best for, and also what it does not do. Namely, we're going to talk about how it fits in compared to medications, how it compares and contrasts with deep brain stimulation, and what people should realistically expect as the result of such a procedure. Let's roll the intro and I'll see you on the other side. Welcome to the Parkinson's Disease Education Show, where we demystify the disease and empower you as the person with Parkinson's disease to reach your true potential. The content contained on this show is for informational purposes only and is not meant to be a replacement for information or advice that you receive from your in-person medical or therapy professionals. If you haven't already, I hope you'll consider subscribing, and for an even more personalized experience, please ask us about our memberships. Now, without further ado, let's start the show. So let's dive into what MRI-guided Focused Ultrasound is and how it works. So essentially, there are hundreds to over 1,000 ultrasound beams. So this is sound waves we're talking about. And they are converged into a single point that is meant to target a very specific place in the brain. And so how it works is MRI is used to specifically and precisely guide where these focused ultrasound beams are going to be aimed for and what lesions in the brain are going to be targeted. In and of themselves, each individual ultrasound beam is too weak to damage tissue, but when they converge at one focal point, the temperature rises enough with the vibrations the ultrasound waves are making to create a tiny controlled lesion. When all is said and done, the lesion is literally no bigger than a grain of rice. Doing the procedure with MRI not only allows precision on location, but also real-time temperature monitoring, as well as immediate feedback on results, and of course, precision down to the millimeter of location of where we're targeting in the brain. This is a procedure done while the individual is awake during the procedure. And in fact, it's not a procedure that requires any sort of anesthesia. Again, there's no incisions, there's no opening the skull. It's all done while the patient is awake and when they can give feedback to the doctors on how they're doing and if it's working. So there's a couple of different specific areas of the brain that are targeted with focused ultrasound, and we're going to be talking about those next. So in those living with tremor-dominant Parkinson's disease, the ventral intermediate nucleus, or the VIM, of the thalamus is where the target will be in this case. By placing a lesion in that specific area of the brain, it can disrupt the faulty circuitry that may result in tremors. For other motor fluctuations and dyskinesia, they will target the globus pallidus internus, or the GPI. So in the underlying condition of Parkinson's disease, the primary diseased neurons are in the substantia nigra pars compacta, which is in the midbrain. But those loss of dopaminergic neurons in the substantia nigra also result in abnormal firing patterns in the other basal ganglia cells, clusters that surround that area, including the globus pallidus internus. And so placing a lesion there with the focused ultrasound can also help to essentially break up the abnormal circuitry and restore a better function in that area. The bottom line is focused ultrasound does not replace dopamine. It doesn't slow disease progression. It's not a disease-modifying treatment, but it does interrupt abnormal signaling patterns that can contribute to tremor and or dyskinesia. The strongest clinical evidence available shows that focused ultrasound particularly will help with tremor that is not mediated by medication, or not mitigated, not improved by medication, especially if the tremor is unilateral or worse on one side. Targeting of the globus pallidus internus, levodopa-induced dyskinesia can also be dealt with focused ultrasound. Those are the two primary targets in Parkinson's. Though this treatment is not well known at this point, it isn't brand new. FDA approval first came out in 2016, specifically on treating essential tremor. So persons with benign essential tremor may not have Parkinson's disease, but in many cases, the tremors can be truly debilitating, tremor being their dominant and their only symptom. In 2018 and beyond, clinical evidence started to mount for tremor-dominated Parkinson's disease, and that's why we're having this conversation now. In 2021 and beyond, they showed that there was evidence that they could improve levodopa-induced dyskinesia with focused ultrasound. And that brings us to this conversation today as well. The essential tremor research actually came before the Parkinson's disease connection. But when it worked for benign essential tremors, they used their noodle and thought, why in the world would this not work for Parkinson's disease when it works for a condition very similar, or at least a symptom of the condition that's very similar? So again, to repeat the emphasis that this is typically done on one side of the brain, and so it treats symptoms on the opposite side of the body. Remember, the motor neurons of our body are on the opposite side of the brain from what moves. So if we move the right arm, those motor neurons, the upper motor neurons, are on the left-hand side, and they cross over at midline and go toward the right side of the body. So, but those signals do have to travel through the basal ganglia, the thalamus, and so forth to get to that opposite side. But just to reiterate that the treatment is on the opposite side of the symptoms. Now there's question of whether this could be done on both sides. Currently, they're never doing this on both sides, but it's being studied to be done on both sides, but it carries with it greater risk because these lesions are permanent and they can't be reversed once they're done. So to just talk about a little bit for a few minutes about how the procedure actually works. So the head is shaved for this procedure because they do have to make some very small incisions in the skull just simply to keep the frame and the helmet in place that's used for the procedure. They don't want anything moving even a millimeter during the procedure, otherwise that could throw the entire thing off. But once they shave the head, they'll put on what's called a stereotactic frame, which basically just keeps the head immobile. Then they put the patient in an MRI scanner and apply a water-cooled helmet on top of that. It does generate a lot of heat to do this, so that water-cooled helmet essentially keeps the patient comfortable and not aware of any overheating or burning sensation. They first test the sound waves, or the sonications as they're called, at low energy, and then from there the patient is asked to do several neurological tests, move a hand or fingers, draw spirals, and also they'll test what their resting tremor is doing at that moment. They gradually will increase the temperature as their lesion, creating that lesion in that area, and then a permanent lesion is created. And of course, then they can test and retest neurologically following the procedure. The really cool thing is that treatment results can be seen in real time, meaning the tremor can often stop during the procedure and the individual and the medical team can both observe that success. Now, it would be appropriate at this point to compare and contrast deep brain stimulation and focused ultrasound just for a couple minutes. So first of all, other than the very surface level places where the helmet needs to mount and so forth, there's no incision, no surgical incision to reach the brain to do the focused ultrasound procedure. It's all done with everything intact, other than keeping that frame in place on the head. The DBS, of course, requires scalp incision and open calvarium. Usually, in other words, the top of the skull is usually removed, or part of it's removed, in order to get into the brain to implant the device. With focused ultrasound, there's no implanted hardware, but with DBS, you have the implanted stimulator in the deep areas of the brain, as well as those are the electrodes, and then also the battery pack is placed under the skin, and wires are run usually just under the surface along the neck and the upper part of the shoulder to get to the battery pack. Focused ultrasound requires no programming, so when it works, it's already ready to go. DBS requires programming that's very specific to that individual and what symptoms are being helped with it. With focused ultrasound, there's a permanent lesion, and there's absolutely no going back once you do it. The DBS, though, is adjustable, and it's actually reversible. The hardware and everything can be removed if it truly is not successful. So again, DBS is adjustable and reversible, whereas focused ultrasound is neither one of those things. Once it's made, it can't be undone, and that's a critical point. Some short-term risks after the procedure could be headache, dizziness, and nausea. Potential neurological side effects that would be unwanted would be balance problems, speech disturbances, numbness, and weakness. Some of those problems could improve over time, but some may persist depending on inflammation and healing afterwards. It's also important to remember this is not a good, not an ideal treatment for somebody who has pronounced bilateral symptoms. For example, if you have severe tremors on both sides, a lot of dyskinesia all over the body, significant cognitive impairment is another contraindication. Also, poor skull density ratio. If the skull is too thick, the sound waves may not pass through adequately. If it's too thin, I guess it could cause skull damage. Don't have a lot more detail about that issue, but essentially the skull has to be the right thickness or it won't work. So to reiterate, who's a good candidate for the procedure, it would be somebody who has medication-refractory tremor. In other words, tremor that doesn't respond well to medication or respond at all to medication, or severe dyskinesia that's typically a levodopa-induced dyskinesia. Also, again, symptoms predominantly on one side versus both. And also, someone who may benefit from focused ultrasound may also be not a great candidate for DBS. Either that, or they really just don't want to go through the process of having implanted hardware and all the risks that come with an open surgery, like infection and so forth. Also, a good candidate is cognitively intact and somebody that does not have dementia. Something else to emphasize as we wrap this up is it's not a first-line treatment. This should not be for someone who's just been diagnosed with Parkinson's or somebody whose symptoms are managed well with medication or other means of treatment. This is for a very specific subset of patients who need extra help when other treatments are not working. Focused ultrasound does not cure Parkinson's, does not slow disease progression, does not improve non-motor symptoms, and it doesn't restore dopamine levels. It does none of those things. It is only symptom targeted. It's not disease modifying. So not that it doesn't work, but it's only for, again, these specific purposes and not for any other changes to be made. What does the future hold for focused ultrasound? Well, again, bilateral treatment is another thing that they're looking into. Also targeting areas like the subthalamic nucleus or nuclei, because there's one on each side. Targeting that area because STN is a target of DBS. So theoretically, maybe STN could be a target for focused ultrasound, but they don't know what the results of that would be at this point. So that's an ongoing area of research or future research. Also, blood barrier opening for drug delivery, which I don't know much more about other than what I found when researching this, but that is a topic that's especially interesting in an emerging area of research, using focused ultrasound to essentially, open up the blood-brain barrier more to deliver drugs in a more effective way. I'm guessing that's what the purpose of that is. So to conclude, MRI-guided focused ultrasound is a powerful non-invasive tool for very specific sets of patients with Parkinson's disease, with those with disabling tremor or dyskinesia on one side of the body. It isn't a cure, it's not reversible, but for the right patient, it literally could be life-changing. But the disease goes on. So obviously working toward a cure is huge and paramount, but doing whatever you can with other means of treatment, and doing whatever you can to help the brain to be as healthy as possible, help the whole body to be as healthy as possible, reduce inflammation, help your mitochondrial health, all those great things should obviously be done in addition to doing something like focused ultrasound to keep your future bright. I hope this was informative to you, and if you're considering focused ultrasound, I hope this was at least a primer in looking into more information about it. Let me know if you've had the procedure done and what benefits you've had from it. But definitely, if you're watching this on the YouTube side of things, I'd love to hear your comments about that. The best way to support the work of this channel and this podcast is to join our memberships, as well as to support our channel sponsors with links found below. Thank you so much. Look forward to seeing you in the next episode. As always, be empowered.